Welcome, cohorts and any pandemic welcomes all of you to this webinar on the role of genomic surveillance and epidemiology, organized by the Southern Africa Center for Infectious Disease Surveillance to bring together the cohorts connecting organizations for regional disease surveillance networks to share their experience with genomic sequencing, especially applied to the current COVID-19 pandemic. The challenges that most of the networks and countries in the global south are facing had to do with capabilities, laboratory capabilities, as well as systems to track and integrate genomic sequencing data and clinical and epidemiological data, so that the questions regarding virulence, transmissibility, etc., can be used to direct control measures. So we thank SACIDS to organize this event, and also for the other presenters that come from the Middle East and Asia, giving us a very broad picture of the experience in trying to respond to the need to identify new variants of COVID-19, but also to give a picture again about how these capabilities can be used for other viruses or other agents that we know or new ones. So thank you for participating, and I'm turned to Professor Mark Rumau, Executive Director of SACIDS, to get us started. Mark.
Ladies and gentlemen, welcome. Perhaps we start with the welcoming video, and then I say one or two words before the speaker starts. Can we have the video, please?
Africa has a high burden of infectious diseases. A new pandemic in Africa can readily be confused with pre-existing infections. It is imperative, therefore, that there be capacity in situ in Africa for early detection and early identification of any new epidemic threats. Through the COVID-19 pandemic, it has also become clear that when a disease hits, health systems are weakened and vulnerabilities are exposed due to the slow allocation of funds and resources to tackle the pandemic. As a victim of a number of diseases, Africa needs to invest heavily in the control of infectious diseases. This goes hand in hand with tackling a problem at source. The SACIDS Foundation for One Health, simply known as SACIDS, is available on the African continent to provide academic and research expertise to support national authorities with appropriate early detection, early identification, early response, and coordination in tackling pandemics. For example, the progressive capacity development of expertise for infectious epidemic diseases, as witnessed by the SACIDS Foundation for One Health, resulted in being alerted to the risk of the global spread of COVID-19, even to Africa, as early as January and February 2020. SACIDS' smart partnerships with global expertise, for example CORDS, can lead to national and global health security. Timely detection and identification cannot be overemphasized. Doing so will improve efficiency in tackling disease, ensuring the health of the people of Africa for generations to come.
ladies and gentlemen, there you are, the welcoming video and notes from my Vice Chancellor and the Chair of the SACIDS Foundation Governing Board. We have 5 speakers representing the networks of codes from Southeast Asia, APA, from the Middle East, SACIDS, and from Africa, EastNet, East Africa Integration Disease Surveillance, and the SACIDS. The first speaker will be Dr. Noah Tegman-Yarden from Israel. Will be giving us a good talk about what they're doing and genomics, and we followed by Placide representing SACIDS and focusing on his own country, what they're doing in the DRC. And I'll also bring back to what message that we got in the video, that is, we're dealing with the, when COVID came in, we in Africa were also dealing with other epidemics. That's a complication which is peculiar to us. And then followed by Dr. Safrina Malik from Indonesia, one country, really multi-country in many ways. And then Dr. Lutwama from EastNet, Uganda Virus Research Institute. And then finally, followed by Dr. Misinzo, starting the argument about, is sequencing affordable?
Yeah.
Up to now, recently, we in CODES have been prominent in the concept of detection error. Now, should we be detection and identification? I think those are some of the things which have come up in the discussion. So without taking too much of our time, Dr. Noah, are you ready?
Yes, sure. I will share my screen.
I'm sorry, Professor Mark, let's just
Can you see it?
Yes, but we lost, Dr. Mali was going to say something before you speak. I don't know what.
So wait.
Well, I think we go ahead, so please go ahead. Please, audience, be as informal but serious as possible.
So I'm honored to be able to share with you all what we have implemented regarding genomic sequencing of SARS-CoV-2 in Israel. Just showing you the different waves we have of positive cases per day. Now we are in our 4th wave, and fortunately it looks like we're coming to an end of the 4th wave, but we have to see what's going to happen, but it looks like we have a decline in positive cases right now. And most of our, over 90% of our positive cases are from the Delta variants, which, as you can see here, these next 2 slides are actually the website from the WHO, which define the VOC, the variants of concern, and variants of interest. So we have alpha, beta, gamma, and delta as variants of concerns, whereas I said in Israel, over 90% are of delta. And the WHO defines the VOCs as those variants which have increase in transmissibility, and in such a way that it changes the COVID-19 epidemiology or increases virulence and there is a decrease in the effectiveness of therapeutics. So it can be either of the three points which they describe. On the other hand, the variants of interests are those defined as having both genetic mutations that predict virulence, such as transmissibility, disease severity, immune escape, and are more prevalent in different countries. So here they are defined, the lambda and the mu. So actually, what are the goals we have in mind when we're thinking of doing a whole genome sequencing is for the benefit of public health in our country or in the region. And this is supposed to help us identify and monitor the different circulating variants. And according to that, we can assess whether we need stricter quarantine in order to prevent the transmission in different regions or other countries. It also helps us to elucidate the biology and the evolutions of the virus, including different aspects with human interactions. It supports the development of molecular diagnostics. We need these sequences to develop new PCR kits according to the different variants, and also to develop new therapeutics, new vaccines or other therapeutics against the virus. And may also help us identify the primary or secondary agent of the SARS-CoV-2 transmission. If I'm thinking more about zoonotic transfer of the virus from different animals, maybe to humans, if we find the same virus with the same sequence as we do in human beings. So all these can actually benefit public health, but this also has to be in a very timely manner. If we do it very slowly, actually it misses the point. The whole program of building up a whole genome sequencing facility actually requires many disciplines. I can't see the whole screen, but okay. It starts with, in Israel, we have the Ministry of Health, the Public Health Services, which have to start with actually defining what the policies are and what the goals are for the sequencing. We have the sequencing, the SARS-CoV-2 diagnostic laboratories, which are routine testing for SARS-CoV-2. In Israel, we have currently about 48 active laboratories. For the sequencing, of course, we need to have patients or positive samples. We need sequencing laboratories with appropriate equipment. Currently in Israel, we have 2 active sequencing laboratories, and the third one is supposed to start soon. These laboratories need professional lab workers, including bioinformaticians, which are supposed to analyze and also interpret the results of the bioinformatics. All this has to have good IT specialists which can transfer data from the different labs to the Ministry of Health in order to know what's going on and to be able to receive the right data. We need good transportation abilities. These transportation abilities have to be done in a timely manner and using the appropriate conditions for transferring the positive samples from the diagnostic labs to the sequencing labs. And we cannot do without having good suppliers which supply us with reagents, with plastics, and support the machines for sequencing. Of course, all this needs also a budget to help it be synchronized and help the collaboration. In Israel, we're using currently the Illumina platform. we're using the MySec, the NextSec, and the NovaSec. As you can see, according to the size is also the capacity of each machine. Of course, there are other platforms, but this is currently what we have, we're using right now in Israel. And just check. Okay, so what are the considerations we had to take in order to start going with the sequencing? As I mentioned before, we have the policy making. We have to set goals as to which samples are we intending to sequence. At the moment, we are sequencing hospitalized people who are positive for the SARS-CoV-2. We're sequencing travelers coming from abroad, and we're sequencing some samples from the community. How many samples should be sequenced per week, per month, depends a lot on the capacity and on the number of positive samples you have. So if there are very few positive cases, then we can maybe sequence everything and you don't have to filter out specific samples. But otherwise, you have to determine how many samples and from which sectors you would like to sequence. We need to locate the samples from the different laboratories, and we need to write guidelines for the laboratories as to how to locate the samples, store them, and send them to the sequencing labs. We have the transports. We have to decide who does the transportation. It has to be done according to quality control, so we don't have degradation of samples. And we have many sites to transport from. So the detecting laboratories which send the samples for sequencing are all over the country, and you need to get the logistics right here. Reception of samples for sequencing is done by the sequencing laboratory, which needs to get the data from the primary laboratories and start library preparation, sequencing, analyze, and send the data. And this also has to be done in a timely manner, because time is a very important factor in all the process. And of course, another major factor in the process is saving the data and reporting it. It's a lot of data, it's a metadata. You need resources for that, and you need to prepare to know who to send the data to and at what formats, in order for people to use it correctly. Of course, you have to think about the ethics, and if data is sent to different people, you don't send the demographic and the personal information on who the sample is taken from, just the sequences. So this is my last slide, just to demonstrate the flow through of the whole process, which is going on now in Israel. We have the SARS-CoV-2 authorized testing labs, which routinely test for SARS-CoV-2. Their results are all the time sent to the Ministry of Health. We have now a computerized system which selects the samples according to the criteria the Ministry of Health has set as to which samples we're interested in sequencing. And as I mentioned before, we're talking about the representative number of samples from the community to understand what is being transmitted here in the community. We're interested in hospitalized patients, and we're interested in travelers coming from different countries to see if we have new variants entering Israel. So these samples are sent to the testing labs, so they get the number of samples which they are supposed to send to the sequencing labs. The sequencing labs perform the sequencing, and the data is again sent to the Ministry of Health. And the sequencing lab also updates the global network as to the results we have in order to share the information with the rest of the world. The Ministry of Health, we send this information to different units in the Ministry of Health, the Epidemiology, and to the testing labs which sent us the samples, and also will be published to the public domain for researchers using only the data of the sequence and not the data of the people from whom the samples were taken. So this is roughly the flow through of the whole process. And again, this needs good coordination and has to be synchronized. And we're all the time looking at how long things take, because time plays a very important role in this whole process. So that's briefly from me. Thank you very much for listening. And I'm here with my director, Dr. Oti Ishai, and here's our mail. If you have any questions, you can also keep in touch with us. Thank you.
Sorry, I was talking to myself. We're going to do, if you could please jot down your questions, put them on the chat, and then we'll have all the speakers answer your questions at the end. The next speaker is Dr. Placide from SACIDS, from DRC. Please, Placide, Bara, carry on.
Thank you, Professor Mark, for the floor. So I'm going to talk on the monitoring of SARS-CoV-2 variant and COVID-19 epidemiology in Democratic Republic of Congo. So the COVID-19 and the DRC occur in different contexts. As you can see, we face many outbreaks at the same time. 4 outbreaks of Ebola virus disease, an outbreak of monkeypox almost at the same period. And now recently, we are facing an outbreak of meningitis with more than 1,000 cases and a lethality reaching about 20%. And thanks to our collaborators, the SACIDS Foundation and also UCLA, who support us during the beginning of this outbreak for early detection of cases and also follow-up of cases. So as in many countries, the COVID-19 outbreak started with imported cases, followed by local transmission. So those imported cases in DRC came from mostly Europe, Asia, and few cases from US and from Africa also. And then we also experienced local transmission after the introduction of the virus in country. So for sequencing, we use the 2 platforms, as you can see here, the Illumina platform with the MySeq and the iSeq 100, and also the nanopore sequencing. So this, according to the availability of reagents, consumable, and also the number of samples to be analyzed. So the first sequences that we got at the beginning of this outbreak allow us to show the many cases of introduction of the virus in the country. As you can see, the circle in green, and also followed by the local transmission circle in red. So at the beginning of this this outbreak, during the first wave, we show that the lineage B1 was prevalent in the DRC, and around January 2021, we had introduction of the variant of concern, the alpha and beta variant in country. They were mostly detected at the west part of the country and also at the southeast part of the country. And at the southeast part of the country, we detected mostly the beta variant, and this is due to the proximity of this part of the country with the South African countries, where this variant was also prevalent. And during the third wave, at the beginning of the third wave, around May 2021, we observed a concomitant circulation of the beta and the delta variant. Then later on, during the third wave, the delta variant became more predominant. And using this sequencing, we are also able to detect the variant C12, which was detected in South Africa, and one case was detected in DRC. He was a Congolese citizen who came from South Africa in mid-July. So this work is also part of the Pathogen Genomics initiative, supported by Africa CDC and also Afro-WHO. And our institute is acting as a sub-regional lab, receiving samples from Cameroon, Central African Republic, Chad, and also Republic of Congo. And using this data, we were able to describe the emergence and spread of the B1620 variant, and which was first detected in Lithuania and then spread out in the US and some countries in Europe, and also detected in some countries in Central and West Africa. And these variants carry many mutations and deletion in the spike protein, and those mutations are also observed in some variant of concern. So the actual situation of COVID-19 in country is, I can say it's getting better, since we are seeing less and less confirmed cases, less than 50 cases per day. And the lethality is around 2%, and less than 2% of healthcare workers was contaminated. And what is also important is to say that we sequence a few samples only, less than 3% of the positive cases. So we need to increase to have, in order to have a better understanding of the local epidemiology. And also in terms of vaccination, we are still far from the target, and using the AstraZeneca and Moderna, those are the two vaccines that are available in country. We receive also doses of Pfizer, and we are waiting for also several doses of Sinovac. So in few days, 3 vaccines will be available in country. So we hope that this will help us to boost the vaccination in the country. So doing sequencing in such as limited resource country, it's challenging, as you can see. It's difficult to get supplies of reagent and equipment, but in the context of a DRC, it was very challenging to deal with concomitant outbreaks. And also, once we get the equipment, we need to maintain and repair and sometimes replace. And this also is challenging, as all repairman, technician and also spare parts are coming from outside of the continent. And also we need to reinforce the training of our lab staff and also in bioinformatics, and also to strengthen the capacity of sequencing in the country, but also at the sub-regional level. So this is my last slide. So thank you very much for your attention.
Thank you, Prasid. We proceed to the third speaker. Please keep your questions. We'll get them at the end. The third speaker is Dr. Safirina Malik.
Thank you, Professor Mark. I will, please allow me to share my screen. So I will make it quick. Okay. Can you see my slides?
Yes, yes.
Okay, okay, I will start my presentation. Thank you for inviting me for this important meeting. I'm very honored to be able to share and learn from you all regarding this pandemic. So in this topic, I will not only talk about Southeast Asia, but mostly about Indonesia, what we have done, what we have been facing, etc. So if you look at the percent of cases sequenced and shared, this is the Southeast Asian country, right? So Singapore is the highest because the cases is not that high, but they shared the genomes, the whole genome sequence the most. While Indonesia here, although now we already surpassed 7,000, but still, because the cases is quite high, the total cases, it's still not high enough to be able to be used as surveillance, but we are working on it. I will talk about how important the genomic surveillance later. So what is the circulating lineages in Asia and Indonesia? It's not exactly the same, although the majority here is the blue one. The latest 2 weeks is the AY23. AY23 is the sublineages of B1617.2, the Delta variant, which is circulating or predominantly circulating in Singapore and Indonesia. And we can also hear it's also the one dominating the Indonesian lineages. If we look at the total percentage of the VOC, Delta plus is the dominating one with a very high percentage starting from June to 5 October when the, I don't know how many peak has occurred in Indonesia, but this is the last high positive cases during this period. So it's almost 90%. Now, if we look carefully to each of some of the South Asian country that has submitted enough, more than 1,000 genomes to the public domain, we could see that most of them are dominated by Delta. Although here in the Philippines, it's still a question mark. They have their peak, but their genomes hasn't been sequenced the last one was sequences from the samples before July. So I cannot say anything about Philippines, but the Cambodia is unique because it's alpha dominating the outbreak. So if you can see here, Indonesia is doing, I should say that, I'm proud to say that Indonesia is doing very well after reaching a very high peak. Almost, I think we have reached 5,000 cases per day at one stage, but now we could suppress the positivity rate until very low. This is just to show you what kind of factors that influence the decreasing positive cases in Indonesia. If you can see here, it's very high, and then it's suddenly very low. Is it because of our vaccination rate? If you look at the vaccination, it's not that high, but you have to remember, we are a very huge country with 270 million people, island nations. So it's not easy to conduct vaccination, but we can now per day reach about 2 million people vaccinated per day. So is it undetected infections, asymptomatic ones? It could be one of the factors that kind of protect the population from the high cases, because our study in March, that was before the Delta variant dominating our lineage, we found that in Jakarta, the capital city of Indonesia, the seroprevalence has reached 44.5%, although the positive case at that time only 8%. And also, the government implemented the restrictions toward community activities, what we call PPKM, since July. So I think this is also play a role in reducing the positive cases. So I think it's a combination of these three and other factors as well. So what kind of specimens that have been sequenced? The priority for sequencing, like what have been explained by previous speakers, specimens from travelers testing positive upon entry to Indonesia, it has to be sequenced. Vaccine failures, breakthrough, reinfections, severe illness and death, outbreaks with unusual characteristics, long COVID cases in children, these are all the priority to be sequenced. And this is just to give you how spread is our country, is from west to east. We are island nations, and it's not easy to collect samples. Like the previous speakers, availability of reagents, availability of the equipment, and also transporting the samples is one of the factors that hindered or prevent us to do more. Okay. So this is just to show you how dynamic the lineages profile in Indonesia. Before we have this, the B1466.2 variant, lineage circulating in Indonesia, and it's originated from the Indonesian population. But now it is suppressed by the new sublineages of the Delta variant. The AY23 is predominantly in Singapore and Indonesia, and this is typical of Indonesian occurring in Indonesian population. So how does this identified by the people who develop the machine learning, the pangolin, that differentiate these two sublineages from the originating Delta? It's because of the shared sequence. I agree that the intellectual property rights should be retained by the submitting institutions, but sharing sequence is important, so we could do the surveillance and observe what is occurring, what is decreasing, etc. The AY.3 and AY24, AY23 and AY24 are both have the typical and characteristic markers of the Delta variant mutations, but they also harbor more mutations in other regions, making them slightly distinct from the original lineage. So this is how we built the genome sequencing capacity in Indonesia. Before we developed the network, we now have the Indonesian Genomic Surveillance Network. Before that, we only have a handful of sequence submitted to the public domain. But now, after we worked together, we built and inaugurated and launched the network. We try to find funding through government and through the Gates Foundation. Thank you for that. We are able to sequence more than 72,000. And in summary, I would like to emphasize that the whole genome sequencing can provide information on virus transmission and spread useful for surveillance. It is, we experience it ourselves, although the Delta variant is still there, out there, they're dominating the lineage in Indonesia. But because of that awareness, we are able to suppress this spread of the virus. WGS is useful for variant identification. Of course, we all know that, needed to understand the emergence of potential new SARS-CoV-2 lineages. Genomic surveillance can provide important information for tracking of new SARS-CoV-2 variants and lineages. Genomic surveillance can generate a rich source of information for tracking SARS-CoV-2 transmission and evolution. And application of genomics in surveillance of COVID-19, and I think it's not only limited to COVID-19, also in other infectious disease, highlighted its usefulness and the nearly real-time response to a public health crisis. Because of the high Delta spread, a few months back in July, the government applied the restrictions. Also because of the cases, positive cases, it's increasing fast. Genomics data can assist and support public health programs for COVID-19. We all agree with this. With that, I would like to thank the Indonesian Genomic Surveillance Network. These are the main institutions that have supported the submission of the and conducted of the sequencing of the whole genome of SARS-CoV-2, and these are the Eijkman team that has contributed to the result that we have now. I think I would like to close my presentation with that. I'm happy to take questions and answer. Thank you very much.
Thank you very much for covering the whole of Southeast Asia and the focus on the countries of Indonesia. So I think go to the next question, please. As usual, jot down your questions and we'll ask them at the end. The next speaker is Dr. Lutwama from ISNET, Uganda. Dr. Lutwama, are you there? Dr. Lutwama, please. Dr. Lutwama, are you there or you dropped out?
He needs to be unmuted.
The host, unmute Dr. Lutwama, please.
Already.
Unmuted.
Okay.
Let me begin off by thanking SACIDS and Ending Pandemics for having invited me to make this presentation. I'm going to present on genomics for managing the COVID-19 pandemic in Uganda. And this is a small, a brief outlook on what I'm going to present. For the sake of time, let me just go straight to this. WHO declared the pandemic in March, and after 10 days, Uganda also got its first case. The early cases were importations from outside of Uganda by travelers who were either coming to visit Uganda or traders who were returning from Southeast Asia and the Middle East countries who returned with the infection. Later on, we saw that the spread was fueled by local transmission within the country. And more recently, we see that the latter stage, which is actually more deadly now, is mostly by local transmission. This was a sequence of interventions to curb COVID-19 in Uganda. Of course, there were many lockdowns and reduction on mass gatherings, introduction of many measures that would be used to stop transmission. There was reduction in public transport. And of course, later on, businesses which had been closed were released. And as these were released, more transmission started. And of course, we had our first wave. And after the numbers of cases had risen very much, again, we had another lockdown, which again was severe to make sure that transmission was reduced. Then, of course, everything turned almost back to normal. And at the beginning of this year, we had thought probably we had controlled the infection for about 4 months. Then later on in May, we started again having a sharp rise in cases. This was again due to two main reasons. There was the introduction of the Delta variant, but at the same time, schools were closed, and students who had been in schools and had a very big number of schools with cases, when they returned to their homes, they sparked off more serious local transmission. So these are the waves that we have been having in the country. The current situation is that, of course, we have had as many as 124,000 cases, about 3,160 deaths, and more than 96,000 recoveries. The case fatality rate is 2.5%, and the positive rate in last 7 days is about 3.2. And of course, we have just seen the epidemic curve. At the moment, we are going down, and hopefully we are not going to have a shoot in the cases again. So what is our genomic capacity? We have a number of laboratories which are involved in sequencing samples in Uganda. We have the MRC, Uganda Virus Research, London School of Hygiene and Tropical Medicine laboratories, which are situated at the Uganda Virus Research Institute. And of course, the platform they use is the Mini-Ion. And we have Macquarie University Molecular Laboratory, which uses the MySeq. We have the National Influenza Center Laboratory at UVRI, also uses the MySeq platform. And then we have the Viral Hemorrhagic Fevers Laboratory at UVRI, which uses both the ISEq and the Mini-Ion. And UVRI is designated as a SARS-CoV-2 reference and genome center by both WHO and Africa CDC. So why are we doing this genomic surveillance in Uganda? Well, the reasons why genomic surveillance is being carried out in many other countries, some of these have already been provided by the previous speakers, is to monitor the appearance and the frequency of circulation of known and new variants of COVID-19, contribute to response by acting as part of the early warning system, to predict likely new waves of infection, to identify importation events, and to help identify clusters of infection and possible dispersal events. So what are our expected outcomes? Well, we hope that we will be getting information to inform us on new mutations of the coronavirus virus in Uganda, to look at changes in transmissibility between different variants, changes in severity of infection between different variants, and contributing to studies on potential impact on diagnostics, for example, using development of accurate diagnostics, and of course, also to contribute to studies of potential impact of vaccines in the country. So what kind of genetic data have we been able to put out? The first genome sequences that we produced from Uganda came out in early May, and this was published by the MRC UVRI RSTH TM unit in September last year. It was demonstrated that the entry of the first virus into the country was from travelers, and this was maintained for quite a time because we had travelers still coming in, travelers coming in by air. When those were stopped, of course, we had the problem of truck drivers coming in, mostly from Kenya, but also from Tanzania. And this continued for quite a while until local transmission was actually more or less maintained around October, November, and coming out with a big wave in November and December. A new variant from Uganda was identified as 8231 strain of SARS virus, which was first reported around that period of time. Here we have our first publication. And the genetic data now of the different circulating strains, more than 15 lineages and sub-lineages which are circulating in Uganda, as seen in that table. The genetic data at UVRI has the capacity to produce about 200 full genome data per month, but we are not really producing that at the moment because of challenges, as we shall see later. As of 28 September, more than 700 full genome have been deposited from Uganda in the international database, with about 96 of these from UVRI, and 75% were from the MRC UVRI London School of Hygiene and Tropical Medicine unit. The laboratory also provides sequence services to some other neighboring countries, like Placid showed. Of course, we have South Sudan, we have Burundi, Rwanda, and Tanzania as countries for which we are responsible, or for which we are supposed to do sequencing if we are requested. And 47 sequences have so far been produced for South Sudan. We have produced 4 publications out of our genomic data. So where have we used this information? For example, we have used this data in following the sequences of 30 cases. Sequencer data has been used to determine the responsible strains or variants compared to underlying condition rather than viral features the sequencer data that has been produced has been used to see whether the strains are the ones which are responsible for the death of patients, or actually just underlying conditions among the patients. The earlier cases were more correlated to patient underlying conditions, but these are the later cases. We see that actually there is very good correlation between the Delta variant virus strains being more responsible for these deaths. We have used the data following up clusters of outbreaks. For example, several prison outbreaks in the northern part of the country showed that they had the same source of the infection. These were truck drivers. And yet the genome from prison outbreaks in other areas, for example, Masaka and Moroto, which are actually very far apart, showed that these clusters were actually separate and different from the clusters that we had seen first. We have also been looking at changes in prevalence of lineages. For example, lineage A viruses in the earlier periods of the pandemic, there was about 39% of the lineages belonging to B, whereas 61 of the strains were lineage A. During the pandemic, there has been a shift with of the variants, with now around December 20, only the A lineage was actually circulating. And I have already talked about the new emerging lineage, which was identified. And in the more recent periods, again, we see that the lineages have turned into the Delta lineage. It is the lineage that is now being seen almost in all the sequence data that we are producing. Turning to the challenges, genome sequencing is still very expensive for our laboratories in the country, both in maintaining the equipment or even getting the equipment themselves, in receiving supplies, getting the supplies to do the sequencing. And of course, we have limited number of personnel, which is a challenge, both personnel for wet lab activities, but also for bioinformatics. Supplies of required reagents still has a lot of bottlenecks, and we spend a lot of time trying to get what we need to get in time. And like I've already said, there is reduced capacity for bioinformatics. As a way forward, we need to expand capacity for production of more genomic data. We need to produce more data regularly and at shorter intervals, such that it may be more useful. This data may be more useful as it comes out. There are still many unanswered questions for which genomic sequencing may provide a better insight. There is need for focused study designs and better sample selection, so that we get better information that is more useful as we produce it. We need to have more labs to be brought on board, such that more data is produced in real time. And of course, securing more funds for genomics and having country buy-in so that more genomic sequencing is done. Most of what is being done is being supported from outside of the country. Let me make these concluding remarks. One of critical values of genomic surveillance is to track the spread of the coronavirus, to identify any potential worrisome new variants, and to inform measures which may be used to control this devastating pandemic. We have seen that there are many mutations which do occur, and this needs to be detected as early as possible. Even though many of these are synonymous mutations, we need to find out which ones of these are actually of concern, which one of these are going to cause outbreaks, and we need to make sure that we detect them as early as possible so as to be able to control the virus in our communities. This is my last slide. Of course, I would like to acknowledge all of those people, and of course, including SACIDS and SCORE Foundation, with whom we have been doing quite a lot of work. And I thank you for your attention. Thank you. Over.
Thank you, Dr. Lutwama. Now, the next speaker will roll us into the next session. Gerard, is this sequencing affordable?
Thank you, Mark. Let me take you through the use of affordable genomic sequencing of SARS-CoV-2 and other viral epidemics in Africa, in particular Tanzania. And in my presentation, I'll cite the personal experience from Tanzania at the Sokoine University of Agriculture, where SACIDS Foundation for One Health is headquartered. In this presentation, I'll focus on complete genome sequencing of SARS coronavirus 2, a viral pathogens affecting humans, and another viral pathogen called Peste de Petit Ruminant, which affects sheep and goats. The latter causes a disease that is simply referred to as a plague of small ruminants. So this disease affects food and nutritional security and livelihoods, especially in people residing in developing countries. So both SARS-CoV-2 and PPR viruses are RNA viruses, and the genes, although are different, but they are comparably small. So the SARS-CoV-2 genome is around 30,000 bases, while the PPR genome is about 16,000 bases. So at the moment, a couple of next generation sequencing platforms are available in Africa and in Tanzania in particular. The first one is called the Iron Torrent, which is based on iron semiconductor sequencing, which is a method of DNA sequencing based on the detection of hydrogen ions that are released during the polymerization of DNA. And the second platform is the Illumina platform, which uses bridge amplification to generate clusters and reversible terminators for sequence determination, in which the sequential fluorescent DNTPs that are colored coded in different ways are incorporated and allowed then later for detection. And the third platform is the PacBio, which is a single molecule real-time sequencing platform based on the properties of zero-mode waveguides. And the fourth one here at the bottom is the Oxford nanopore sequencing technology, which uses a new generation of sensing technology that uses nanopores, or simply to call them nanoscale holes, embedded in high-tech electronics that perform precise molecular detection of bases based on their different shapes between the A, T, C, and G. And these are detected as they transit along the nanopore. So in Tanzania, Iron Torrent, Illumina, and so the Iron Torrent, Illumina, and nanopore sequencing platforms are available. So at SACIDS, we have widely used the nanopore sequencing technology because of its versatility. We do have both the MK1B shown here on the left and the MK1C shown here on the right. The MK1C comes together with a screen which you can monitor the sequencing in real time, but also with the sequencer itself. And at the bottom, you have a GPU-powered computer that processes the data in real time. With the MK1B, you would need to have a mini IT on the side, which will process your data, but along with the computer screen in which you are able to visualize the data. The other thing that we have acquired here at SACIDS in Tanzania is the so-called Bento Lab. So this is a mobile PCR or thermocycler that comes with along with a centrifuge and an electrophoresis machine. So this is also battery powered. So you could have the nanopore sequencers together with your thermocycler and electrophoresis machine, both battery powered. And that is, it allows you to conduct sequencing even when you are in the remote areas of Tanzania. So at SACIDS, we have used nanopore sequencing both in the laboratory and in the field. So in this slide, sequencing is performed in the laboratory setting. We have sequenced SARS coronavirus 2, and we provided expertise to the Ministry of Health in Tanzania to sequence SARS-CoV-2 in order to track the viral variants. So at SACIDS, we have deployed the nanopore sequencers in the field to sequence viruses that cause transboundary animal diseases, such as Peste de Petit ruminant and African swine fever. So we have a 4x4 vehicle that is designed to navigate the difficult terrains of Africa. And this vehicle is fully equipped with tools to enable sequencing there in the field. So in our 4x4 mobile genomics laboratory, this vehicle is equipped with a fridge and a refrigerator where we can put our supplies and power outlets. So the AC, because we have an inverter in the car. So with this mobile genomics laboratory, we are able to follow the tracks of viruses at source, providing genomics data early enough before the use of complex laboratory-based sequencing platforms such as Ion Torrent and Illumina. So we have performed the complete genome sequencing of Peste de Petit ruminovirus that affects sheep and goats from the southern part of Tanzania in Momba, but also in the famous Ngorongoro, located in northern Tanzania. And these are the one of the first complete genomes of this virus from this country. So we have also sequenced SARS coronavirus 2, and in this one I'm showing the alignment of the Tanzanian isolates as compared to the Wuhan isolate, which is at the top. And so we have been able to follow the viral variants circulating in the country during this first, second, and third wave of COVID-19. So we are convinced that with field deployable genomics, we will be able to achieve community level syndromic and genomic surveillance and contribute to ending pandemics promptly before they become unmanageable. We feel that the combination of our AFIA data, a syndromic surveillance tool, a digital mobile application for disease reporting and surveillance, with our mobile genomics for disease diagnostics and monitoring of pathogen diversity and variations, plus a powerful public policy engagement, we will greatly contribute to achieving community level 1 health security. So we thank Ending Pandemics and Skoll Foundation for providing us with the resources needed to conduct this work. Allow me now to invite one of our panelists, Professor Hans Nauwink from the University of Ghent in Belgium, who has developed Pathosense. Pathosense is using nanopore sequencing to conduct diagnosis and characterization of veterinary viral pathogens. Welcome, Hans, for a brief 5 minutes presentation. Thank you.
Okay. Thank you, Gerald. So I will try to share my screen. Hope this will work. It should. I hope you see it now.
Yes.
Yeah.
Okay, I'll open the presentation mode. So I'm working at the University of Ghent, Belgium, and we developed a spin-off from our lab activities, that's Pathosense. And what we do is we, and that's very revolutionary. So what we do is we diagnose infectious disease in medicine. And it is already, people are already paying for that. So I heard a lot of people discussing on affordability of sequencing. So what is I will show you later. I will have a look. So in the veterinary world, and that's not quite different from human world, there are a lot of problems that we had in the past with diagnosis. The first one is selection. So if you want to do a PCR, you have to use your primer. So you know already in advance, you have a foreknowledge which virus or what bacteria that you want to look for. So this is not that easy then for the very beginning, and especially with COVID-19, SARS-CoV-2, that's not the only one that is circulating. And I see already in Belgium nowadays, there's a lot of discussion. Everybody thinks on COVID-19, but there are a lot of other ones. Like nowadays, there's an influenza C, and we detected that with our system that is circulating. So there are a lot of things to discuss about the selection. Another thing is lack of information. If we get material from the field, that's always a problem to get information. And you know, if you don't know what to look for, then and together with your PCR, you get totally bananas. Then you have the problem number 3, that the sample quality. Everybody who's in diagnostics knows that this is a burden. This is really a nightmare, especially in the veterinary world. You get all types of samples, and this is always having a negative impact on your diagnostics. So what we did was we're having a platform, I call it, Pathosense. So we developed and patented a new swab that we use in animals, but could also be used in humans. We have an app developed so that the vets can easily put their clinical signs on the screen. The swab has a QR code, so this is coded. This is scanned with your smartphone. Then it comes to the lab, and then in the lab we just do the you know, 3rd generation sequencing with the nanopore sequencing, and this is due to the fact that we have a special swab. This takes only a few hours before we can enter the thing already in the Manayan. Then afterwards we get results, and we can give it's not only COVID-19, but we discover all the virus, all the pathogens, all the bacteria that are in the sample. And then we make a kind of an interpretation. At this moment, this is very individual, but in the future, I'm convinced with the artificial intelligence that this will go faster. And then at the end, we can give some advices to the people. So this is our setup. It's a gridiron already at this moment. So we run a lot of samples on a daily basis. And we don't need prior selection. So we just take virus and bacteria out of the sample, whatever it is. And very interesting is by doing this, if you have a big load, then you're not only identifying, but you're also directly sequencing what's in it. And this is a huge power that we can offer to not only vets, but also pharmaceutical companies if they want to know what's in a sample. So this is what we have. And you know, what I see is, this is from a veterinary perspective, but I'm convinced that this approach could also be of benefit for human medicine, because as vets, we are further away in diagnostics than in human medicine. In human medicine, people always talk about flu, but there are a lot of etiologies behind flu, a lot of virus, a lot of bacteria, and mostly even in Belgium, nobody cares about the etiology. And this is, of course, extremely. It's as a veterinary virologist, I'm really sometimes surprised that we are so far behind if you compare it with the veterinary medicine. So I'm proud to be a vet. And these systems should be more installed for use in humans. And I'm looking forward. I have already contacts here at the university hospital to install this system also there to go fast in identification of some certain difficult diseases. So this is what we have at this moment. We run already a lot of samples in a day, and we're looking forward to expand that not only in Europe, but also we have some collaboration with Gerald to roll this thing also out in Africa to help to have better insights of what is circulating. And we start with the vet stuff, but I would be very happy to roll this also over on humans. So this is what I had to say, Gerald. So I hope it was of interest to the audience.
Thank you very much, Hans. It's good.
Thank you very much, Hans. Yeah, and that's very timely. Now we've come to the question answers, and then the panel. I don't know, Dr. Smolinski, if you've been fed with the questions from the audience.
I see they are flowing in the Q&A section. I also realize we're running short on time here. So what I thought I would do is give an opportunity to hear from Dr. Georgina Murphy from the Bill and Melinda Gates Foundation, who's one of the panelists, to share any comments or reflections that she would like to share based on what she's heard. And then we can try to cover as many Q&As as we can with the remaining time. So please, Dr. Georgina.
Thank you so much. And thank you for all the wonderful presentations. It's really remarkable to see all of the work that's happening internationally. These kinds of sessions are so important to ground us in the day-to-day work that's happening in your labs, in your countries, and it's really, that's where all the progress takes place. So thank you all for taking the time to put together and present your presentation so well. I think from the Gates Foundation perspective, there's so many different aspects of genomic surveillance, genomics sequencing that can be of such great value for global health. And we saw that very clearly through a number of the presentations. But in particular, I'd love to just pick up on a few themes, and we certainly don't have enough time to talk about them in depth here. But one of them is that the COVID pandemic, whilst of course it's been a traumatic and really devastating time internationally, for the genomic sequencing world, I think it's been a time where there's been a huge amount of innovation, huge amount of capacity building and international attention on the use and the value of genomic sequencing to inform public health decisions, which is a wonderful opportunity. And I would love to see it not be something that stops at the end of the COVID pandemic. What we would love to see happening, and I'm sure all of you have this top of mind as well, is to take all of the capacity that's been built during this time and has been, of course, leveraged, pre-existing capacity was leveraged too, and to see it embedded and integrated into integrated surveillance systems, to be able to be used for a number of different pathogens, a number of different public health questions, and truly integrated as a set of important tools that works together with the epidemiologists, with the public health decision makers, with the immunologists, the different scientific disciplines, to be able to put genomic sequencing and genomic surveillance really right at the center of a number of different public health questions and pathogens beyond the current COVID-19 pandemic. So that's something we'd love to continue a conversation on, but in order to do that, of course, there's a number of different issues that have arisen. We heard time and time again challenges with supply chains, with markets. It's still incredibly expensive, particularly in a lot of the geographies that the Gates Foundation works in, namely Africa and South Asia, to even just get the resources to labs, to get them there in a timely manner and in an affordable way. So that's an area of interest that we are working closely with a number of different partners to try and dig into, trying to understand really what are the bottlenecks here, what are the challenges, and most importantly, what are the potential solutions. I think another area of important development is something that I've just touched on, which is this integration with public health decision making and the epidemiology, really trying to take a thoughtful approach to how do we choose the samples that get sequenced? What is that sampling framework? What questions are we truly trying to answer using genomic sequencing? And how will that vary depending on the public health question at hand, the pathogen to be addressed, etc.? And how can we leverage the expertise that exists in some other spheres, such as epidemiology, surveillance, immunology, etc., to be able to bring all of that together and make sure that we're not sequencing for sequencing's sake, but really rather answering specific public health questions. And I think the presentations today demonstrated that very well. Every speaker spoke very clearly about the different public health and scientific questions that can be addressed with the power of sequencing. So I'll leave it there for now because we are short on time. I could probably talk for hours about all of the different areas where there's excitement in this field and also, of course, opportunity to improve. But I'll pass back over because I know that there are quite a number of questions and answers and look forward to the further discussion. I'm happy myself to take any questions that may arise as well. Thank you.
Great, thank you very much. And thank you to all the speakers for very illuminating discussions. What we can do now is try to get through as many questions as possible, and those who can stay on, we'll keep going for a little bit over the time for those who are able to do so. So I think what I'll do right now is try to get one question per speaker. And so if you could make your answers as brief as possible, that would be helpful. And then, of course, we have all of the questions. And so we can try to have persons who those questions are directed to. If we don't have time to answer them, we can send you a response afterward. So going back to Israel, it seemed like one of the real questions that popped up from a few people is, you talked about the importance of sequencing people coming into Israel from visitors. And the question is, do you sequence all positive tests coming from travelers, or how do you manage that particular issue?
Yes, this is one of our priorities, is sequencing all the positives coming inside of Israel. I think our criteria are very similar to what Dr. Safarina Malik presented, so this is very similar.
Great, and I will add a question of my own to you. Is how are you connecting the epidemiology with the genomic sequencing? Because that seems to be a big issue in many places where we have the capability expanding for doing genomic sequencing, but it's only as good as the epidemiology that surrounds those particular cases. And I'm wondering, how do you make those connections?
Well, the connections are daily, hourly. Whenever we find something which may raise suspicion or a need for resampling of a person, or considering breakthrough, yes. But now we have managed to make things computerized, so things are mostly online with between the epidemiologist and the sequencing labs, and a lot of Zooms, discussions, phone calls, constant on an almost hourly basis. As soon as you get something which raises an alert, you go for it. That's the only way at the moment.
Great. Thank you very much. These may not be in the order of the speakers because the questions came in at different times, but there was a question for Dr. Safarina about the data that you showed for Cambodia, and what are the hypotheses that you have that we're not seeing the Delta strain in Cambodia, or even the same level of infections as some of the neighboring countries? Do you have any insight to share on that?
Thank you, Mark. Okay, I don't have any information regarding the Cambodia, but as the surrounding nations are all dominantly by the Delta variant, and it is unique that the Cambodia still have the Alpha variant. If you look at the date of sample collection, they are still up to date, right? So it's quite recent samples. So I don't have the answer for that, unfortunately. I'm sorry.
No worries. So the other question for you is, can you briefly talk about the vaccination situation in your country? And are you seeing vaccine hesitancy? And if so, what are some of the reasons, or how are you trying to overcome that? I think we have a little frozen situation here. So now you're back.
Okay, thank you for the question. Of course, vaccine hesitancy is found everywhere in the world. Okay. I'm just you, so the connection is will be better, right? Is that okay?
Yes, we can hear you.
Can you hear me? Hello.
Yes.
Can you hear me?
Yes, we can hear you.
Sorry, the connection is okay. Okay, so the hesitation is happening all the time. Sometimes the people rejected the healthcare worker, and that happens several times. But I think trying to make people understand it's not easy, the benefit of vaccination, but the restriction applied by the government more or less nudge people to accept vaccination, because if you are not vaccinated, you are difficult to go anywhere. That's the bargaining of being offered by the government. Does
Great.
that answer your question?
Yes, thank you very much.
You're welcome.
A question that has come in for all of the speakers is, given the work that you're doing in genomic sequencing, are you seeing that this ability is providing some ability, if you will, for looking at future predictions of changes in strains? And how do you see genomic sequencing adding to the ability to look at predicting what changes may be occurring in the viruses? And that's for anybody who would like to take that, including our panelists.
What I can say about Israel is that we're looking, we have monitored and non-monitored. We're not looking only for the variants of concern or interest. We take notice of the different changes, looking at certain mutations which may be more relevant for virulence. And once things pop up a few times, we look at them closer, and it's a big question on how we can recognize a variant before it spreads, and we can try and stop it before it spreads. So we're also looking at keeping in mind the non-monitored variants and trying to understand the importance of the different mutations. So,
Yes, maybe I can add on, Mark. I think the question was focusing on whether we can use the genomic data we have together with computer predictions to see and predict how the virus is going to evolve. Computer models may be there, but the virus may not behave as what the predictions can be. And so you have to really wait for what is happening in the real world and be ahead of the curve to capture these variations, because the virus, what it's trying to do is to be able to fit to the receptor, the ACE2, so that it can transmit easily evade the immune system, and maybe cause less severe disease. So when you have a variant that causes more severe disease, the virus is not healthy. And so you really have to be monitoring so that you can capture these so-called mistakes that the virus is making. So you really have to use genomics and be ahead of the curve and be able to capture these variations and their relatedness to clinical data in real life. Thank you.
Great.
Can I add an answer?
Yes,
okay.
please.
I will turn off the video for connection. So it is not always easy to capture before the variant spread, right? Because like us, the Indonesian we are island countries. When something happens, it will not be detected as fast as we want to. For example, if it is outside, the Java Island is the main island, but if it is happening in the remote area, so what we do is that we observe whether there is a particular increase, a sudden or unusual cases, and then we send it for sequencing. If it is, the circulating lineage, like what I mentioned, Indonesia has a particular typical circulating lineage, then we will observe further. But if it is unknown, then we will have to collect more samples from that particular area and the surrounding area. I think that's what of the thing that we should do in a spread country like Indonesia.
Great. So a question that has arisen that was inspired by some of the comments made by you, Dr. Noah, and also Professor Hans and Professor Gerald. The idea of genomic sequencing helping to also look at the flow of viruses between animals to humans. I'm wondering, what are the challenges and opportunities that exist to make sure we're doing robust sequencing in the animal community as well as in the human communities, and what are you seeing, or how do we improve that amount of sequencing that it certainly seems to be underrepresented.
So maybe I can take that one. So I'm very interested in that, let's say, linkage that we should make, the link that we should make in between what is circulating in animals and what is circulating in humans. So that is why we launched also that Pathosense. We really, in a short term, we would like to come up with a dashboard of what is circulating. Not only we will not only have identities of viruses, but also their sequences. And very beautiful would be to have the same dashboard in humans, so that you have, and then not only looking to COVID-19. This is the most wrong approach of human medicine nowadays. That is, and it will become clear with the winter. There's so many viruses circulating that it will be a nightmare based on let's say symptoms already, to go for collecting material and try to get some identification out of it. So I think it will be a very low percentage that will be positive here. I'm talking then with European eyes. So it will be a nightmare, and it's really a pity. They should really go for for revolutionary diagnostics, to have also from the human side a dashboard of the viruses that are circulating, not only COVID-19, but the whole picture. So that, as like you said, that we in the long term can see things in humans, see things in animals, and there see the overflow, not only zoonosis, but also reverse zoonosis. And then we will learn a lot of information. We can get a lot of information. We lack that at this moment, because there are a lot of, for instance, rotaviruses, even influenza virus, they just jump without seeing a lot of things. So we will have a better view if those dashboards exist, and if they start to communicate with each other. They call it One Health, but I can tell you the One Health at this moment is dominated by human medicine, and there is totally not enough interest from the veterinary side. And this is crucial. We really have to come together and make that nice, beautiful top platform that is called One Health. And then we still lack one dashboard. That's the dashboard of the wild, which is, of course, a nightmare to set up that thing. But it's extremely important that, let's say, the veterinary side and the human side, that they come together, building, I would call it then the one dashboard, and have a full knowledge on what is coming from what animal or human being and is jumping to another. So this is extremely crucial. This world at this moment is overcrowded, too many people, too many animals. And a very important thing is, people are getting, and also animals are getting in the environment of a lot of wild animals. And then I think we're just, I can promise that there are a lot of disasters coming up to us. So we really need those dashboards as soon as possible to face a lot of problems that will come up to us in the near future.
Great, thank you. Anyone else?
I'll make a comment on that.
Please.
I mean, this week there's an article in Lancet, which is showing people go back. When you get a bigger outbreak, now COVID, before AIDS, and then you go back, you find, oh, maybe it started a few years ago. Now, when I listen to what Gerard has talked about, and also what Dr. Georgina was talking about, sequencing leading to public health decisions, conceptually, there seems to me that we're going to have to look at the balance between over-centralized decisions and decisions at the local level. And then to go back to what we saw from the DRC, and it was referred to in the video, that if only you had these types of diagnostics, like Hans was referring to, and affordable genomics linked up with ability to pick up syndromes early at a fairly local level, and they're robust, that enables for people locally to begin to be concerned. And that is not to in any way to obviate the over vertical systems, but the vertical systems is operating now in an efficient environment. And in the post-COVID era, we really have to look at now how do we bring it down to as close as possible to the animal in this case, and very low subnational level, rather than continue on the basis of privileged technology. Started PCR was privileged, now sequencing becomes privileged. The science now and the technology looking like we can be a little bit more decentralized and be more effective.
Great, thank you. And maybe perhaps the final question, that's an intriguing question that for Dr. Noah, that Israel has comparatively had one of the highest vaccination rates, yet we're still seeing a spike in COVID-19 cases that may not all be attributable to just the rise of the Delta variant. And we're wondering if you have any comments on why you're seeing the increased cases in Israel.
Yes, so there may be several answers to this. Is that we are the first who started vaccination, so there is some cases where there is lower vaccination after the second dose, so that's why we started the third dose. Another answer is that more than 60% of the people who got COVID-19 were those who were not vaccinated, kids, mainly kids. So the Delta was more transmissive in children in our cases. And now it seems that also after the third vaccination, there's now some reduction in the transmission. So I think the combination of reduced immunity due to it's been more than half a year after being vaccinated, and due to the fact that children were not vaccinated, and the Delta mostly was transmitted in children.
Great, thank you for sharing that. So I realize we are quite over time now, and we want to be respectful of everyone who's been able to join. I want to personally thank all of the speakers for really very, very interesting presentations, and to our panelists for joining and adding their perspectives. So in closing the meeting, I just want to make sure to over to Professor Mark at SACIDS if he has any final comments. But otherwise, we really appreciate you attending today, and we look forward to inviting you to further conferences of the Courts Network. Professor Mark.
Well, thank you, and thank you, members of the panel. Thank you, speakers. Thank you, attendants. I see we've dropped by 60, but it's still over 100. That's extremely good response. I think, I'm going to be a bit selfish on the cause perspective. I think this is one of the values of cause, that we're able to gather from at least 3 continents now, and I think we're now coming into a phase where what Dr. Georgina asked, to start internalizing it. How do these technologies respond to public health, as opposed to respond to public health officials? And that really means, we look at, the enablers technologies, enabling analysis, and try and outsmart the pathogen by picking it up at source, geographically and sociologically.
Right. Well, with that, thank you, everybody, and have a good evening or good day, depending on where you're joining from, and stay safe out there.
Thank you. Bye-bye.
Bye-bye.
Thank you,
Thank you very
everybody.
much, everyone.
Everybody. Bye-bye.
Karibu, as we say in Tanzania. Welcome to Tanzania. Karibu.